We are going to talk about very interesting topics as part of the Advanced Pediatric Endocrinology Symposium. This is being organized under the banner of Mediclasses, Growth Society and Regency Hormone with support from Novo Nordisk. So we started off with pediatric endocrine awareness using workshops, and around 2011 we started the practical pediatric endocrine course. Then we conducted workshops across the country. We had a workshop in Patna also, I think 10 years ago. Then we had got PPC across the country. In Jaipur we conducted. Then we realized that just doing workshop, it will require a huge amount of time and other factors. So we started on more of awareness programs on social media and YouTube channels. Then we started our on-site fellowship, that is 2017. And then we started the online program because that will give more access to people across the country. And now we have the mobile application, we have got the online fellowship programs, the other factors which are available in that regards. So over the last 10 years, we actually, when there was no COVID, we used to have every month one program here and there. And we had got huge number of practical courses, workshop across the country. But now, good or bad or whatever, we've got more of online activities which are there. And this time we have a hybrid program. So the first Advanced Pediatric Endocrinology Symposium happened in 2017. I think Dr. Sanjay and Dr. Pradeep were both there in that program. Dr. Amit was also there in that program. And Dr. Hemchand, who is part of this program, also was part of that program at that time. 2 years back, we had another big program with our on-site course, which was in 2019. Again, many of our friends were there, Dr. Pragya and a lot of other friends. Dr. Pratik was also there at that time. Then last year, we did it more in an online mode, and today it's a hybrid mode. So all of you can access our YouTube channel, which now has got a huge number of videos on nearly every topic of pediatric endocrinology. You can access them from there. You can go to our website, which provides a lot of information and courses which are available, including fellowship programs, diploma programs for postgraduates. And we have got 3 specific exclusive grand rounds which happen on a complimentary basis. Every month we have one for advanced in a fellow or a pediatric endocrinology perspective, one for postgraduates. And recently we have started a postgraduate lecture series for postgraduates covering the basic topics in that regards. You can access our publication
on what is the current perspectives of newer treatments that are available as far as growth improvement, rational use of growth promoting therapy, and how far we are from routinely using these drugs in clinical practice. So I have just put across 4 scenarios which we are likely to encounter. A 15-year-old child with Intana stage 3 with short stature and height is currently below the 3rd percentile. How helpful would it be to start this child on aromatase inhibitor therapy? Second is a child with achondroplasia with a severely depleted height Z score at minus 5.6. Where are we as far as helping these children? An adolescent boy in Tanner stage 3 with short stature, height below the 3rd percentile. How rational is it if we suggest GNH Analog Therapy to postpone his epiphyseal fusion, and what is the benefit he gets in terms of his final height? And lastly, regarding routine use of growth hormone therapy and growth hormone deficiency, what is new in 2021? So let us go on. The first group of drugs which we are going to look into is aromatase inhibitors. Aromatase inhibitors, basic physiology, all of us are aware. It's an enzyme in the cytochrome P450, heme protein containing enzyme located in the endoplasmic reticulum. It is located, the receptors for the aromatase are located mainly in the bone, in the ends of the long bone, in the genitalia, that is in the Leydig and germ cells of the testis, and it is also present in the brain. And we are worried about the drug, and we are focusing on its action based on its location in these particular areas. Aromatase inhibitors can be 1st generation, 2nd generation, 3rd generation, and it can be reversible non-steroidal or steroidal irreversible. Anastrozole and letrozole are commonly prescribed drugs that are used in routine clinical practice. So the primary problem in front of the treating clinician is how helpful is aromatase inhibitor therapy in short children with idiopathic short stature? How helpful is it to induce puberty in constitutional delay, and what is its impact on the final height? How does it help in growth hormone deficiency who present to us late in puberty? Is it rational to use aromatase inhibitors early in puberty? Is it safe in girls? And does it impact the bone health or the reproductive capacity? I think a significant amount of data is present on the utility of aromatase in idiopathic short stature who present to us late in puberty. This is a summary of studies which have been performed at various parts of the world, where adolescents have been studied on with ISS on aromatase inhibitor therapy, especially when they receive either GH plus letrozole or GH alone. And a lot of data is there to support the fact that, number one, there is an improvement in the short-term growth. Number two, there is an improvement in the predicted adult height because the rate of bone age advancement is slowed down. And number three, that automatically this is going to reflect in an improved final height. I think the purpose of treatment seems quite logical. I think usage of aromatase inhibitor therapy is like driving a car on a steep plane. You don't drive using you don't accelerate using the accelerator, but you use the handbrake to move up and down. I think it is something like that. You use aromatase inhibitors, postpone the fusion of the epiphysis, and give them more time to grow. The logic is perfectly understandable, and there is good amount of data to support the usage of ISS with a little bit of caution. So what are the points of caution? We'll come to it in a bit. The second group is utility of aromatase inhibitors to induce puberty. Conventionally, we tend to use the testosterone therapy to induce puberty in children with constitutional delay. These are a couple of studies who have looked into who have compared letrozole versus intramuscular testosterone in inducing puberty and its impact on the final height and the sexual maturation. I think these data, which have looked into small sample sizes of around 30 to 40 children, clearly tell us, yes, it's a very good oral alternative. It may be as safe as testosterone and with good amount of long-term safety, but we need more data. How does it help in boys with GHD who come to us late in puberty? You are desperate. You want something to prolong their years of growth because they have come to you late. This is one study which I could lay my hands on a large subset of 115 children. And they did observe that there is an improvement in the height set score. And there is a slowness which is achieved as far as the bone age advancement is concerned. But this is a single study. But this is a very promising, and it may be very useful in specific clinical situation. And lastly, is it rational to use aromatase inhibitors earlier on in puberty so that you start early and prolong their years of puberty? I think this one study which has looked into children from various centers in Finland clearly says no. Aromatase inhibitors has to come to you as a rescue in the end of the puberty. Earlier in puberty, if you start, it really does not add. It may be efficacious, but it does not add to the ultimate measure of improving final height. So I think a summary of whatever we have said till now clearly tells us that aromatase inhibitor therapy is a promising drug in children with ISS who come to us late and we are desperate. But can it be routinely used in clinical practice? There are three particular concerns. One, what does it do? What is its impact on the skeletal health? People have described all kinds of vertebral wedge abnormalities in children with ISS who have been treated with letrozole versus I think there are a lot of flaws in that study in the sense that a baseline thing was not recorded. But I think the impact of this drug on bone architecture and vertebral morphology should be understood more clearly before routinely recommending it for usage in children with ISS who come to us late. Impact on reproductive capacity. So when you give aromatase and you increase the LH, FSH, and total testosterone, is it going to impact the Sertoli cell function? That is a big question in front of all practitioners. I think these are two studies which have looked into it. I think the second study is a very extensively conducted and a well-designed study who clearly demonstrate that as children who receive letrozole as well as testosterone have an increase in their gonadotrophins, an increase in the testosterone, the AMH level decreased similarly. It reassures that there is good amount of safety for the developing seminiferous tubules. So I think this may be something which is reassuring, but you need more studies, prospective studies on a long-term basis. And lastly, there is a lot of worry in terms of practitioners whether, when you use aromatase inhibitors in girls, is it going to result in something like hyperandrogenism? What is the long-term safety? This study looked into the utility of aromatase inhibitors in girls with central precocious puberty to improve their final height. I think this is a Gale study, which was done in different centers of Greece. They received either GnRH analogs or anastrozole, and clearly they showed that there's efficacy in terms of reduction in bone age advancements, reflecting in a gain in the predicted adult height in children who receive a combination of aromatase inhibitors and GnRH analog. And very beautifully, they demonstrated that there is no clinical, there is no biochemical evidence of hyperandrogenism during the course of therapy, and the bone health is optimal in these children. There is nothing detrimental. But I think this is a single center study done on a specific cohort of people from one particular country. I think these are promising results which reassure us that yes, these drugs seem to be safe on a long run. I think the conclusion of this particular part of the talk is, does aromatase inhibitors help in short ISS children? Most likely, yes. Does it help in induction of puberty as an alternative to conventional testosterone therapy when it is indicated? Maybe. We will get more answers in the days to come. Does aromatase help in children with GST who come at the fag end and we are desperate? Maybe we need more data, but it is probably safe as far as the bone health, probably safe as far as the reproductive capacity, probably safe in the female sex. So I think aromatase inhibitors in ISS towards the end of puberty is something where we are looking at with a lot of hope and anticipation in the days to come. Coming to the second new elucidation is the vosoritide. This is a drug, a new drug, a C-peptide, T-type natriuretic peptide analog, which has been recently developed. And you very well know, and it has been approved for usage by the European Union in children with achondroplasia, with a genetic diagnosis, with a chronological age more than 2 years, and epiphyses are unfused. I think they reiterate that the diagnosis is not based on just skeletal survey, but also on the a genetic diagnosis. The USA is considering it, and it's probably going to be approved in the days to come. So how does it work? All of us very well know achondroplasia is caused by a gain of function mutation in the fibroblast growth factor receptor 3, which is a negative regulator of bone growth. This drug acts to restore the chondrogenesis through its binding to the natriuretic peptide receptor, resulting in a downstream signaling of the overactive FGFR gene. So it is a very promising drug, and all of us as practitioners know that when we encounter a child with achondroplasia, we stare, we give a gloomy stare as if we don't have anything to offer to help these children, and parents are desperate. Can we do something? This is a very, very, very promising result. It is a recombinant C-natriuretic peptide analog. It stimulates endochondral ossification. Authors described here have described phase 2 and phase 3 trials, described large groups of children who have received this drug in doses from 15 to 30 microgram per kg as a single injection. And as far as this new drug and the experience with this drug, which has been published in 3 major journal articles, as practitioners, we are interested to know what is the side effect profile. Number 2, we want to know what is the efficacy. Number 3, what it does to the bone turnover markers. And number 4, we want to know what it does to the abnormal body proportions, which is also a burning problem in children with achondroplasia. Number 1, side effects. The side effects, majority of them experience side effects, but the major side effects are minimal. Only 4 of them have experienced in this particular study: tonsillar hypertrophy, thyroglossal cyst, obstructive sleep apnea syndrome, and grade 3 syrinx. So I think you need to have an active surveillance for side effects whenever you're putting these children on this particular drug and explaining the pros and cons. Very importantly, what is the benefit? Taking an injection daily for one particular year, what is it going to add to my final height? I think the data from this says in a dose of 15 to 30 microgram per kg, 15 microgram per kg, 1.1 to 2.3 per year of treatment, increment in growth velocity. I think this is a very, very, very promising observation. When you have a per year increment of about 1.1 to 2.3, cumulatively, when you're going to add it, maybe over a prolonged duration of about 5 or 6 years, you're going to add a substantial chunk to the final height. And that is going to lead to an improved quality of life and improved happiness in the child. So I think this improved growth velocity, as very beautifully shown here, You see the graphs on the left side. You see the height for age Z score showing a positive increase in children who have been treated with 15 microgram per kg and 30 microgram per kg. What does it do on the biomarkers, bone turnover markers? There is a significant increase in the urinary cyclic GMP and CXM, that is collagen X marker, with this particular injection. So I think this is again a positive result in terms of the bone health optimization. And lastly, we are really worried about the proportions. You can see very beautifully in this graph, the red line and the blue line, but the major side effects are minimal. So I think for all practical purposes, it seems to be a safe, persistent, growth promoting effect in children with achondroplasia if you give it for a period of 2 years. This drug is not available for commercial use in India. Probably the GROW Society, the Indian Society of Pediatric and Adolescent Endocrinology should work together as a team and make this drug available for our patients so that our patients with achondroplasia are benefited. The third group of drug, very interesting drug, is the GNRH analog therapy to improve the final height. Our own Anurag sir was a part of this beautiful consensus statement. Anurag sir and Archana ma'am represent the ISPE in this consensus statement, and a very, very, very well-written, practical, crisp consensus on the utility of GNRH analog therapy to improve final height. So as a practitioner, what are the situations you are going to encounter the utility of GNRH analogs to improve the final height? The first one, you're going to look into a child who has precocious puberty as well as growth hormone deficiency because of an intracranial malignancy. The intracranial malignancy has triggered precocious puberty. The intracranial tumor has caused growth hormone deficiency. The second one is a GHT who comes to you late. He has good amount of sex hormones, but you want to postpone the puberty so that the child gets more years of growth. Number three, you're looking at a child with ISS who comes to you in the peripubertal age group. You find that this child will be benefited if the menses are postponed, if the puberty is postponed. Are you justified in using it? And number four, you're looking at a child with SGA and early puberty. I think you cannot use the same approach to all the four groups. They are entirely heterogeneous. What are we looking at? The first group, combined GH and GNRH analog therapy to children who have malignancy. The malignancy is responsible for both of them, and you have treated the malignancy. I think this is a summary of data which is available, and it clearly says the predicted adult height improves with 2 to 4 years of GNRH analog therapy. The consensus statement on the utility reviewed this very beautiful literature and clearly told, yes, please go ahead. Whenever you have a child with treated for malignancy resulting in GHT and central precocious puberty, go ahead and treat them. I think a strong consideration for GH therapy and GNRH therapy is recommended in these children because you're going to have a good improvement in the predicted adult height. The second group is a group where you are going to have children with GHT who are short at the onset of puberty. These are some of the studies which have reviewed this particular aspect. A group of 21 children from Chile and 21 children from the Dutch registry. And predicted adult height, the authors describe, roughly increases by around 6 to 8 centimeters with 2 years of GNRH analog therapy. So remember, this group of children, the consensus statement says, whenever you have an insufficient height at the pubertal onset, where you have a strong risk of a shortened adult height, have a thought process. You may have to initiate these children on GNRH and GH. So I think whenever you have GHT and precocious puberty, you have to go in for GNRH analog therapy. Whenever you have GHT who are short at the onset of puberty, you may have to consider GNRH analog therapy. Now, the third group, a very, very difficult group, is a child with ISS who is short at the onset of puberty. Are you justified in giving them GNRH analog treatment alone? I think the answer for that, the consensus statement clearly says no. ISS, you really don't have an improved height, especially in the peripubertal age group when they come to you between 7 to 8 years. The final height does not improve with isolated growth GNRH analog treatment alone. So the answer is very clear. The same group of children, who have ISS and who are short and who enter into puberty, are you justified in giving GnRH plus GH treatment? I think these are two interesting studies, one from Venezuela and one from France. They observe that, yes, when you give, it's again the story of, riding a steep plane in a heavy traffic jam. You are climbing up with the help of your handbrake and not with the help of your accelerator. So you're giving the handbrake and you're trying to suppress the puberty, and you're giving GH and pushing the final height. So how justified are you? These studies describe that there is a short-term slowing of the growth velocity, but the gain in final height cannot be guaranteed. So these studies say an average gain is about 2 to 5 centimeters with GnRH and GH treatment combined. So what is it that happened when you block these children who have ISS with GnRH analogs? Once you withhold the GnRH analogs, you have a rapid progress in the bone age, number one. Number two, they don't experience the spurt in puberty which they would experience without GnRH analog therapy. The GnRH analog therapy kind of blunts the pubertal spurt. So even though you may prolong the years of growth, they don't have a spurt. And once you withhold or stop the GnRH analog therapy, they run like a rabbit and they lose the race. Instead of going slowly like the tortoise and winning the race, they go rapidly like a rabbit and they lose the race. So be careful. The consensus statement says it is experimental. Individualized short-term benefit, yes, it may reduce the growth velocity and bone age advancement, but they may not experience the spurt and the bone age may advance very rapidly. So individualized cost-benefit analysis, it is experimental. I think an individual case-to-case decision has to be taken. The last group is in a child with SGA. I think the consensus statement clearly says children who are short at the onset of puberty, who have a subnormal predicted adult height, give a strong consideration for a combination of GnRH and GH, especially if they are SGA. The predicted height increases by 6.6 centimeters with 2 years. And this is significant, especially in SGA baby, because this is a chunk addition to the final height. But the question is, when should it be started? The guidelines say when they are less than 140, I think this 140 number should be Indianized, and an Indianized number should be taken into consideration. But yes, you should give a strong consideration. So what is the role of GnRH analogs to improve final height? When you have malignancy with resultant GH deficiency, yes, give a combination of GnRH and GH. GHT, who do not experience catch-up growth and who are short, individualized. GnRH plus GH to ISS is experimental, individualized. SGA, who are short at the onset of puberty, most likely, yes. And coming to the last scenario, routine use of GH for GHT, I think the Growth Hormone Research Society statement, a very, very beautifully written document, which is available freely, which is, because I'm towards the end of the time, I may not go through the whole thing. The key thing is the Pediatric Endocrine Society guidelines and the Growth Hormone Research Society guidelines kind of complement each other. They have finer differences, but they complement each other. And the GHRS guidelines had an Indian representation. The oxological criteria are slightly different. The testing for genetic testing are slightly different. And regarding growth hormone deficiency, the cutoff has been slightly lowered. And they also suffice that if the clinical index of suspicion is strong, stick to one growth hormone stimulation test. And the genetic test, what is the sequence and the indications, they have very clearly described. And regarding the neuroimaging, they say an earlier consideration for MRA should be made, and hypoplastic pituitary should not be taken as a single criteria for hypopituitarism. And whenever you have a high pretest probability, a single test, they say, is sufficient. And in GHT, the GH levels less than 7 nanogram per ml is making a diagnosis of GHT. Regarding priming, any adolescent with delayed puberty, please do prime. That is what the statement says. And these are the guidelines, dosages for growth hormone deficiency, which are described in the guidelines. And the guidelines very beautifully describe that we should be using a weight or a body surface area based dose. And that is very important, not an IGF based dose, but IGF has its own utility in the management of children with GHT. And it has very beautifully described what is suboptimal response. Whenever you have increase in height SDS less than 0.3, you will have to consider it as an suboptimal response. The guidelines are shifting us to use the height Z scores more and more rather than just sticking to the improvement in oxology based on the growth chart. And IGF based guidelines have also been given, very simple ones, how the dosages, the increment in the dose and the IGF is going to match, and how we should reduce the dose with persistent rise in the IGF has also been described very well in the guidelines. Just to sum up, how useful are aromatase inhibitors in growth promotion? It is indeed very useful in ISS who present to us late in adolescence. Be careful, they may be useful in CDGP, they may be useful in GHTs who present late. They are described to be safe as far as girls are concerned, bone health and reproductive access is concerned, but we need more prospective studies. Positretide, very safe, useful drug as per current available literature. If it is available in India, it will be a boon for our children with achondroplasia. GNRH analog treatment, strongly recommended in children who have combined GHT and precocious puberty in intracranial malignancy, and GHTs who are short at the onset of puberty. SGAs have a low threshold to initiate these children on GNRH analog treatment. ISS, it is a cat on the wall situation. The new guidelines of Growth Hormone Research Society lay more strict oxological criteria, less emphasis on GH stimulation tests, more emphasis on the MRI brain, rational dosing, oxology-based adjustment, and appropriate and unanswered controversy on priming. I hope we are able to answer these common burning questions that we encounter in our clinical practice. Thank you, everybody, for your patient hearing.
Thanks a lot, Hemchand, for this wonderful discussion, especially on these three important aspects of aromatase inhibitors, GNRH analog, and the GH therapy. We'll take a couple of questions at this point of time. So there's one issue which is basically there in terms of the question is, what is the guideline for use of GNRH and GH in early puberty, but no other comorbidity? So you mentioned that if somebody has got a setting of radiation, they often have a concomitant precocious puberty and GHD. In other situations, let's say somebody is presented a bit late with regards to precocious puberty, what would you do in that setting, Dr. Hemchand?
Yeah, I think it has to be an individualized decision, as I said, in the case-to-case basis. I think one should read the consensus statement on management of GNRH analogs in early puberty, of which Anurag sir was an article. It's such a very, very beautifully drafted manuscript. Every word of the manuscript gives you a lot of insight on management of the case. Such a well-prepared document. I think the guideline on usage of combined GNRH analog plus GH should be individualized based on the birth weight, number one. If you have an SGA baby, have a low index, low threshold to initiate. If it's an AGA, be careful. Look at the underlying diagnosis. If it's GHT and you have a compromised final height, you may have to consider have a low threshold to initiate these children. However, if it's an ISS with low predicted adult height, you have to have a higher threshold to initiate these children on GNRH plus GH treatment. And as the consensus statement says, it is described as experimental. It is not advised for routine clinical practice. I think the cost benefit analysis has to be presented in front of the patient. The cost of the treatment and the anticipated increase in final height with this combination therapy should be put in taken the correct perspective, and a right decision has to be taken. It's a very challenging decision to make, but I think we have to keep all these factors and make a wise decision for these children.
I think that's a very, very important point, that whatever we are talking about are based upon evidences which are there and they keep on changing. New evidences will come definitely. But first aim should be to do no harm. So the main aim would be that the child remains normal. So if it is not required, we should not try to make it more like a cosmetic measure, but only in children who are really short, we should try to do all these things which are plus minus experimental at an early stage. I think that was a very, very wonderful talk, Dr. Hemchand. Thanks a lot for sparing your time. IGF-1 and the role of IGF-1 and IGF-BP3 in the whole parameters. So Dr. Sajili,